म्यूट नहीं ना।
हाँ लाइव हो रहा है, एक सेकंड
कट इट करें।
मैं लाइव कर रही हूँ लाइव।
लाइट है ना।
Good morning to everyone. Good morning and welcome you all to the Core Connect live webinar on IVF in PCOS women. How is it different? So today we have with us Dr.Rashmi Prasad, who is the gynecologist and infertility specialist, MBBS DGO, PG, DN, ART and reproductive medicine from University in Shillong, Holstein, Kiel, Germany. Madam, thank you so much for accepting the invitation and being a part of this webinar and accepting the proposal of the webinar. Here you go, ma'am.
Okay, thank you. Good morning, everyone. Today our topic is PCOS. As you know, PCOS is a very common problem in reproductive age in the female age group. But today the topic is related with PCOS with infertility. With infertility, whether the IVF is better or not. So let us see some PCOS pathophysiology. The pathophysiology of the PCOS, although still not entirely clear, it is mainly due to the hormonal imbalance caused by the both hyperandrogenism and the hyperinsulinemia. So it is a multifactorial disease. We cannot predict that this is the only one reason why PCOS occurs. Maybe it's hereditary, maybe hormonal imbalance. But one of the, as you can see on the screen, that androgen hormone is more found in the case of PCOS, and hyperinsulinemia is found out in most of cases of the PCOS. Now, in the case of in the patient of the PCOS, mostly we found insulin resistance is there, which there is a, you can see on the screen. Then what is the chain reaction of hyperinsulinemia? It is divided into the 3 categories, in which we can see that decreased SHBG produced by the liver is increased ovarian production of the androgen and disordered release of the LH and FSH ratio, which leads to the oligoanovulation or hyperandrogenism, which again leads to the PCOS. So there is more raised in the LH hormone, less in the FSH, which leads to the anovulation. Anovulation leads to the less availability of the egg, which leads to the infertility in most of cases of the PCOS. Next, please. What is the pathophysiology of PCOS? As you can see, please go to the back. Please go to the back. Yes. As you can see on the screen that hypothalamus stimulates pituitary gland, which secretes more LH and less FSH. Increased in the LH, which leads to acts on the theca cell, which leads to the increased androgen excess, which leads to hirsutism. So in the most of patients, you can see that there is a excessive hair growth, male-like pattern on the face, and due to the decreased FSH, which is mostly affect granulosa cells, there is more chance of follicle arrest, which leads to the anovulation, which leads to the infertility. And obesity itself increases the chance of insulin resistance. Next slide. So what may be the treatment of PCOS? In the brief, first of all, the lifestyle modification is the first line treatment of PCOS, which includes the weight reduction, type of the food, avoidance of the junk food, exercise. It should be included in the PCOS. By itself reducing the lifestyle modification or reducing the weight, patient can recover from the PCOS. It's because there is a more chance of diabetic mellitus and cerebrovascular disease in PCOS patients. So when the patient modify the lifestyle it reduces the risk for DM and CV diseases, and avoid effect of the insulinemia, reduces insulin resistance with the help of insulin sensitizer. Another point is it reduces production and circulating level of androgen and protect endometrium against effect of unopposed estrogen and induced ovulation to achieve the pregnancy. So by itself reducing the weight and exercise, all these benefits is going to come to the patient of the PCOS for the case of infertility. Next slide. PCOS treatment for those who pursuing pregnancy is a separate topic. Next. PCOS treatment for those pursuing pregnancy. The ideal treatment option for PCOS patient related to fertility regulation is still a matter of controversy. You cannot say that this one is the best and this one is the best. It depends upon the individual of the PCOS patient. Recently, consensus ASRM sponsored PCOS consensus working group was reached on infertility treatment for PCOS patient, which include the use of letrozole with or without adjunct. Second is the exogenous gonadotropin, and third is laparoscopic ovarian drilling. Sometimes leads to the less decrease in the LH and increase in the FSH, which leads to the ovulation. And last option is IVF. Before any definite treatment is adopted for the achieving pregnancy, weight loss in the obese patient is a primary objective, which has a tremendous impact on achieving success of a specific treatment. As we have already discussed in the previous slide, that weight reduction itself reduces the LH level and which leads to the ovulation. Next. In vitro fertilization in the patient of PCOS, indications are failure of non-pharmacological and clomiphene citrate treatment, plus failure of gonadotropin, which is mostly used in IUI. Second is high success rate of pregnancies. However, women with the PCOS tends to have hypersensitive to gonadotropin therapy, therefore have an increased rate of multiple pregnancy and OHSS, ovarian hyperstimulation syndrome, because there is more and the more chances of becoming of follicles, which leads to the hyperstimulation. And the clinical pregnancy rate in PCOS women is 30 to 35%. So in the IVF, the result is better, but there is a more chance of multiple pregnancy or OHSS may be there. That should be properly managed during the trigger of the PCOS patient in IVF. Next. Management of infertile PCOS IVM, immature oocyte collection in vitro maturation, possible future treatment for the PCOS. Gonadotropin protocols. There are so many protocols we can use in IVF for the follicle manufacturing. So it depends on the individual doctors, individual infertility specialist, which protocol he or she is going to follow. But these are the 3-4 one of the most commonly used protocols, like gonadotropin only, gonadotropin with letrozole, gonadotropin with GnRH analogs, and gonadotropin with GnRH antagonist. So dose of gonadotropin, it depends upon the age, BMI, height, and weight. As you can see on the screen, if the female is less than 30, PCOS FSH hyper responders, we should advise to give 37.5, 50, or 75 according to her age and weight. And normal responders, if the age is less than 30, we can use 150 IUI. So the dose should be less because there is more number of the follicles, there is more chance of the hyperstimulation. And if the age is 30 to 35, we can use 75 to 100 international unit of RFSH. In the similar age group, in normal responders, we use 150 international unit. And in the more than 35 years of age, 150 international unit is recommended. And in the same age scenario, we can start the dose of gonadotropin with 225 international unit, because there is a risk of hyper stimulation of the ovary. That's why the dose of the FSH is less in PCOS hyperresponders in compared to the normal responders. Now the question is, which gonadotropin in the PCOS is better? There is debate and the debate and the debate. HMG or recombinant FSH. As you know that HMG is composed of both FSH and LH. So you know that in PCOS patient there is more LH. So you should avoid LH in every situations. So it is in our practice, I personally recommend RFSH, because as you see that elevated LH is frequently encountered in the PCOS. Excessive LH secretion with detrimental effect on its reproductive functions, and use of SS only product rather than HMG seems more logical. Which protocol should be used in PCOS? The question arises, which protocol? So in standard cases, not in the PCOS, but in the every infertile patient, when we are stimulating any infertile patients, there is so many protocols, literatures are mentioned in the book, and different doctors are using different protocols. It depends upon the individual choices, but most common are, you are seeing the most common protocols like a step up, a step down, and sequential protocols, in which step all we increase the dose gradually from 75 112.5 international unit to 150 unit, and then triggered by the SCG. And a step down, we decrease the dose, starting with the high dose, like from the 150 international unit to 112.5 international unit to 75 international unit, and followed by the trigger with the SCG. In sequential protocols, starting with the low dose, 75 international unit, gradually increases the dose up to 150, then again decline with the 75 with the starting dose, and triggered if the follicle size is more than 14 mm, we trigger it by SCG. But remember that in PCOS patient, triggering with the SCG is very dangerous. It may lead to the hyperstimulation OHHS syndromes. So be careful. Super long down regulation in follicular phase in PCOS is from day 2 of the menstrual cycle, control COS daily for 28 days. Combined oral contraceptives daily for 28 days, and on the day 21 of the combined oral contraceptives, SC of the subcutaneous injection of the triptorelin 0.5 milligram or the pride 0.5 milligram, and continued until the triggering day. On the next menstrual day 3, GNT is started high, and there is a more chance, with the more chance of the oocyte maturation, there is more chance. Next, early administration of a GnRH analogs in PCOS. Early follicular phase GnRH analogs pre-treatment for 3 consecutive days, which leads to the significant decrease of the OHHS, high chemical pregnancy rate. T trends towards greater number of the M2 oocytes and 2 PN oocytes and embryo, and the high CPR, reduced incidence of moderate to severe OHHS, high CPR per embryo transfer. So these are the consequences. Now these are the topics when the early antagonist, conventional antagonist, and the long agonist protocols. There are so many protocols. कि उनके हाथ में क्यों नहीं, हमको अपने खुद करना है ना, हम उन पर डिपेंड कर रहे हैं. लीव हो जाए.
ये मैम आपका,
क्योंकि वो उस पर हम डिपेंड कर रहे हैं ना, हमको रुकना पड़ रहा है. हम कहाँ थे पहले देख. ठीक है. As you can see on the screen, early antagonist, conventional antagonist, and long antagonist protocols. So we can see that oral contraceptive pills should be started before the previous cycle, and GnRH agonist, it will be triggered by the GnRH agonist and followed by this SCG. So flexibility in the starting ovarian stimulation at different phases of the menstrual cycle. Traditional theory, single cohort of antral follicle grows only at a beginning of the follicle phase, and recent it has been demonstrated that there are 2 or 3 waves of the follicular growth. Antral follicle in the luteal phase had similar development potentials. Now, COS can be started on any day of the menstrual cycle. No difference if the COS is started in early follicular phase or late follicular phase or luteal phase. No difference in the number of the mature oocytes retrieved, viable embryo rate per oocyte retrieved, CPR and IR. Double, dual, duplex ovarian stimulation is very common in nowadays. It can be used in poor responders, which there are so many protocols, but most protocols is Shanghai protocols. Second is subsequent COS course in follicular and luteal phase, retrieving more oocytes in the COS2. COS2 exert a priming effect that increase the ovarian response to COS2. As you can see on the screen, that the cycle day 3, clomid or letrozole is started. And on the 5th day, FSH and LH is given to the patient for the follicle manufacturing, and it is stimulated by GnRH antagonist, GnRH agonist or SCG trigger. But in the PCOS, most preferably GnRH agonist. It should be triggered by GnRH agonist because there is a chances of hyperstimulation. Now on the day 13, first oocyte retrieval is done, and after that again clomid or letrozole is given, and again stimulated by the FSH and LH and triggered on the day 25th. With it on the triggering agent is maybe the GnRH agonist or SCG. On the second time, it may maybe it is your choice, but I think that in the first one, one should prefer the GnRH agonist, and that oocytes will be retrieved. So in this protocol, we can retrieve as much as more and the more number of the follicles in the poor responders. Double stimulation in the same ovarian cycle, which is also called DO stimulation, to maximize the number of oocytes retrieved from the poor prognosis patient. A multi-center experience and SWOT analysis shows all these type of outcomes. So double stimulation, which is also called Shanghai protocol version, as I have already said, that clomiphene citrate should be started from the day 2, and on the day 5 we start with gonadotropin, and we monitor the follicles, and when the follicle again manufactures, we trigger it with GnRH agonist, and again on the 5th day the clomiphene citrate or letrozole should be started, and along after that FSH is started, and we again stimulate and retrieve the follicles. Antagonist protocol with an FSH dose 300 international per day. It includes COS started on the 6th day post COS. COS2 started right after OR1, triggering GnRH analogs in both COS and COS2. Similar number of the oocytes and blastocysts in the COS1 and 2, twice as many oocytes and blastocysts in a 4-week time frame. Double trigger. Usually we do, nowadays we usually do the double trigger because the quality of the oocytes will be more improvised after double triggering, which it can be done with GnRH analogs together with SCG or GnRH agonist and SCG. Both can be used simultaneously 40 and 34 hours prior to the OR respectively. SCG and the GnRH agonist both has its benefit and disadvantage. In SCG, It has the long half-life, 34 hours. Serum HCG detectable up to 14 days after the injection, and it has prolonged leukotropic effect. But in GnRH agonist, it has short half-life, about 4 hours, produces an LH and FSH surge with amplitude similar to those seen in normal ovulatory cycle. Quick and irascible leukocytosis is found in GnRH and agonist. Now, indications are treatment of empty follicle syndrome, failure to retrieve oocytes in the patient undergoing PCOS with at least 5 mature follicles, more than 15 mm on the day of the HCG. And second is the high rate of the immature oocytes. The number of the retrieved mature oocytes improved by this regime. So in poor responders, the significant increase in number of retrieved oocytes, mature oocytes, fertilized embryos, PR, IR, and newborn transferred embryo rate. Normal responders, GnRH agonist and the standard HCG can be used. Significantly improved LBR and high number of the embryo of the excellent quality. Individualization of the starting FSH dose for prevention of the OHSS is number 1 is a PCOS, depends upon the age, AMH, and BMI. And again, the history of the previous OHSS. If the patient has previous history of the OHSS, we should be very careful. Now, the decision for the women for the controlled ovarian hyperstimulation for IVF ICSI includes 2 headings. If the patient has PCOS already diagnosed, and if the patient is non-PCOS. In PCOS cases, if the age is less than 30, it is divided into the age-wise 3 categories. If the age is 30, below the 30 years, between the 30 to 40 years, and 40 to 45 years. In below the 30 years, it should be started with a 75 international unit. In the 30 to 40 years, 100 international unit, and the 40 to 45 years, 150 IU. So there are so many consequences of this regime. If the AMH level of the baseline is less than 0.7 nanogram per ml, we add 50 international unit, which will, if the BMI is less than 18 kg per square meter, it should we can minus the 25 international unit. So depends upon the age, BMI, all these factors can decide that which dose should be started. As you can see in the age group between 30 to 40, if the BMI is 30 to 35 kilo per square meter, we add 25 international unit. Moderate or severe OHSS in previous cycle, if there is a history, any history, we minus 25 international unit. In the similar way, in the age of 40 to 45 years group, if we start 150 IU, and if the AMH level at the baseline is 5.1 to 10 nanogram per ml, we minus 25 IU. And if the BMI is more than 35 kg, we plus 50 international unit. And if AMH level at the baseline is more than 10 nanogram per ml, minus 25 international unit. But overall, it depends upon the individualization of the patient. It is not fixed. Suppose if the age is between 30 to 40 years and the BMI is not as far as the literature, so we can decide that what is the age, what is the BMI, what is the weight, what is the height, what is the ovarian reserve. All these factors can decide that which dose should be started. GnRH agonist administration on the day of the HCG for prevention of the OHSS in long-acting agonist protocol. 60 patients undergoing COS undergoing long agonist E2 level on the day of the HCG above 5,000 nanogram per dl. 52 patients received single dose of the cetrolix 0.25 milligram on the day of the HCG, and 8 patients received 2 doses of 20.25 milligram per day cetrolix started on the day before the day of the HCG. Moderate OHSS about 10%, and no case of the severe OHSS may be found. Now, conclusion is long-acting FSH is a similar CPR, slightly higher OHSS compared with the daily recombinant FSH, and FSH biosimilars are cheaper, biological and clinical, non-inferior to the originator product, and SC subcutaneous progesterone avoid the side effect of vaginal or intramuscular, because the intramuscular progesterone is very painful and sometimes it is a pyrogenic also. So further, the RCT are needed to confirm the value, minimum number of the injection protocol, no routine antagonist on the day of the SCG for the prevention of OHSS, progesterone to block the LS surge, effective oral alternatives, required total freezing and delayed transfer. These protocols are valuable. Flexibility in the starting ovarian stimulation, double triggering, individualization of the starting FSH dose for the previous OHSS. As I said before, that it is not fixed regimes for the any PCOS patient that this is only given and this is not can be given. It depends upon the doctor's individualization of the patient. What is the previous history of OHSS? What is the BMI? What is the weight? What is the ovarian reserve? All can decide that which protocol is very suitable. But in our day-to-day practice, we stimulate the PCOS patient with RFSH, not with the HMG, because HMG has the more LH effect, which leads to the hirsutism or male-like pattern and less number of the egg. But if the FSH is used, it should be used very carefully, because in PCOS patient, there is more chance to become more and more egg. OHSS will be there. So we should be very careful while stimulating the patient of the PCOS patient, which is undergoing the infertility treatment. And the triggering is very important. We should not rely SCG. In our practice, we don't stimulate the PCOS patient by the SCG. Nowadays, we stimulate it simply by the Lipride or GnRH agonist. So there is a less chance of the OHSS. So in PCOS patient, there is two aim for the infertility. In infertile patient, we should collect egg. Our first aim is to collect the egg. Egg should be there, but we should control the medium production of the egg by giving the proper dose of gonadotropin. And again, on the day of the triggering, we should avoid the hyperstimulation. So we should always use in our practice. This is my personal experience. In our practice, we used to do with GnRH agonists like Lipride injection. We always avoid SCG in PCOS patient for the triggering. That's why OHSS can be prevented. Thank you. I hope that you can understand something about the PCOS patient undergoing the IVF treatment while stimulation and while the triggering. Any questions, please?
Ma'am, thank you so much for elaborating and making us simple to understand about how IVF is different in PCOS, what are the protocols to be followed, how we have to manage PCOS. So thank you so much, ma'am. There are a lot of viewers who have joined us live, and all the queries will be forwarded to you, ma'am, which will be further taken. And I thank you for accepting the invitation. And I thank all the viewers who have joined us today to attend the webinar. Thank you so much, ma'am. Thank you all.
Thank you. Thank you.